without further ado, let's dive in. Please help me welcome our first guest, Senator Sheldon Whitehouse from Rhode Island. Morning.
Morning.
How are you?
Well, Adriel, thank you.
Thanks so much for being here today. So I think it would be journalistic malpractice if I didn't start with a question about these dueling votes that the Senate will be taking tomorrow. One on Obamacare subsidies, one on health savings accounts. We assume that neither will get the 60 to advance. After this happens, for the rest of the year into January to the next funding cliff, does this exercise promote maybe some bipartisanship towards getting a health care deal, or does it just dig people in more into their position?
It's often helpful in the Senate to have sort of clearing votes so that people get their own bill out of their system and then they can move on knowing that they didn't get it done. This is a little bit different. I think that both in the House and the Senate, Democrats are completely unified on a simple extension of the Affordable Care credits. And it's simple and it's easy to understand, and it's what, frankly, a lot of Republicans said they wanted. So I think we're in pretty good shape in that regard. I think the other side has got all sorts of problems, like no coherent policy to begin with. Mostly that party has identified itself with what it's against rather than what it's for. So it'll be interesting to see how much Republican support the so-called Republican proposal even gets, and how many Republicans defect to support the Democrat proposal to give themselves a little election cover next November. So it's hard to know where that leads, but I think that after the votes are done, there's still a big opening to get this done. I think Republicans understand that while they control the House and the Senate and the White House, they will be held accountable for what they in fact have done, which is to take down this enormously important support, which trends very heavily into red states. So they're hurting a lot of their own constituents in a hard way.
Did Democrats set somewhat unrealistic expectations for a subsidy renewal? I mean, it's something that people are counting on, but the cost of extending them, even for a few years, is pretty ginormous.
You had, what was it, a dozen House Republicans say that they want to extend it for 2 years? Okay. We'll do 3. You said 2. Let's solve this.
So if our audience were to sort of lock in on something, obviously the subsidies expire at the end of the year, but is the real crunch time at the end of January at the next funding cliff, or is that getting too
I think
far?
there's a lot of crunch between now and the actual crunch time, because all across the country people are getting their renewals, their notices, they're having to make choices about where they sign up, they're being sticker shocked with doubling and tripling of their rates. They're having to consider whether they actually have to go bare without insurance because they can't possibly afford the new rates. And all of that leads into January. So I think we're in much more of a continuing period of sticker shock and public chagrin.
You have taken a strong interest on Finance Committee and elsewhere in boosting primary care when we talk about, the delivery system. You've come at it, among other ways, from the provider payment side.
Yep.
What are the policy levers that are available in this kind of an environment where cutbacks in federal spending could weigh heavily on such foundational care?
Well, I guess I start from the proposition that the faster we can get away from fee-for-service and the further we can get away from it, the better off we are. And the more we can unclench the grip of the specialists on the reimbursement system, the better off we are. So moving primary care to a more ascendant position and reimbursing primary care more sensibly, I think those are very capable. There are things that we're very capable of doing in a bipartisan way. And some of it is just continuing to protect and defend the ACOs and to the accountable care organizations. We had 2 outstanding ones in Rhode Island that kind of set the mark nationally. I had a war for years with CMS under the Obama administration because they kept screwing around with the ACOs in stupid ways, and we had to keep correcting stuff. But the ACO, I think, has worked out really well. There's simple things. I'd love to require prior authorization for prior authorizations and exclude anybody who's in a value-based care system from prior authorizations, because in theory the economic alignment is already there. So there are lots of things we can do, big and small, to move the system away from the bad place it still is and move forward into the value-based care system that already shows a lot of promise.
Your work with Senator Cassidy, among others, how
Senator Barrasso, Senator Crapo.
How's that going to play out next year? Are there avenues once we get through, or is it harder in an election year?
Even when Republicans were in peak repeal Obamacare, there was never any effort to undo the ACOs. There was never any effort to undo CMMI. There was never any attack on the move from fee-for-service to value-based care. So I think that remains a wide open lane. And I think, frankly, it's one that in the last administration, the Democrats, we really could have capitalized a lot more on it. And we just didn't have the level of interest and ambition that we should have in the Biden administration to move that forward as far as we could have. So I think it's a wide open lane, and I think it's a bipartisan lane, and I think it's a highly consequential lane.
When you talk to clinicians, I mean, patients are showing up with increasingly complex needs. They want more time than doctors have. There's growing mistrust with the medical establishment. There's burnout. What's your message when you talk to the practitioners who are facing all these challenges?
Well, it seems to me that it's more the primary care practitioners that are facing those challenges. And I think the more we can drive both better reimbursement to primary care, more flexibility, again, like the ACO model, to primary care, and put them more in the position of being sort of the general contractor. I mean, if you analogize to somebody building a house or doing a home repair, you hire a general contractor. And the general contractor is the person who sorts out the tile person, the electrician, the plumber, and all of that. In the healthcare system, your primary care provider is kind of your GC, and yet they don't have any central role in working to get your specialists together. And very often you have people with complex conditions who are seeing different doctors, and they're not coordinated at all. Electronic health records helped a little, but those have kind of gotten more challenging in recent years. So I think there's a lot of room to be gained by empowering primary care practices more and freeing them up more from the tedium of the rinse and repeat fee-for-service model, where you have to allocate your time in like 12-minute increments.
You were pretty out front with legislation addressing the opioid crisis.
Yep.
And we saw the president last week signing reauthorization, I think, of the Support Act, which drew on your work. What is next? Is this a problem? I mean, it obviously weighs on a lot of lawmakers' minds, but what is sort of the next phase of the congressional response?
For me, the next phase is figuring out how to integrate the CCBHCs, the new behavioral health centers, into the existing architecture of treatment for addiction, mental health, behavioral health, and so forth. People who operate in that space are certifiable heroes, and it's very much like razzle-dazzle and deal with your situations as they present themselves. And when you set up relationships, it tends to be informal. It's being done kind of ground up. What I hope, and what we're going to try to do in Rhode Island, is to see if the CCBHCs, once they're up and standing and have their resources, create the added increment of resource so that you can actually put the keystone in the arch and build an architecture of care for people facing addiction, behavioral health, and mental health concerns. And you can't really ask people while they're in such a mode of immediate response to try to figure that out. if they don't have the resources, so that if they do figure it out, they can't do it anyway. If the CCBHCs provide that resource, that could be a true, I mean, we use the word game changer out here pretty profligately, but that actually could be a real game changer, so that the healthcare system, in a really orderly, sensible, and known way, addressed these cases. And it involves going beyond just the medical profession. I mean, one of the groups that needs to be involved a lot is police departments and first responders. And so, you know, the CCBHCs provide a framework where so many institutional interests can come together. So that's my next big hope, and I'm hoping that we can use Rhode Island as a model.
Mm-hmm. And there's, I imagine, some bipartisan energy around that.
Everybody liked the CCBHCs. They're there anyway. So let's try to figure out how they can not only do their thing, but also transform the architecture of behavioral health care.
So I'd be remiss if I didn't ask you whether you have taken Secretary Kennedy up on his invitation to call. He said you have his cell phone number. I don't know if that's true. We have a meeting. You have a meeting.
And I'm looking forward to it. Rhode Island is getting completely screwed by CMS in terms of reimbursement. We're part of a regional market with Massachusetts, Rhode Island, and Connecticut virtually indistinguishable. And CMS, in fact, calls it a region. And then they allow Rhode Island to be paid like 20% less than Connecticut or Massachusetts. And it's intensely frustrating and infuriating. And they've never given a red hot damn about that problem. So I'm hoping that with Secretary Kennedy, they'll start to take an interest. There's a model out there called the AHEAD model, which could be used to ameliorate that discrepancy, and we are in it. So that's going to be one of the topics. The other is that we still do a lousy job with end-of-life care. We still have a lot of Medicare rules and Medicaid rules, but mostly Medicare rules that might make sense in a hypothetical, you know, all patients fee-for-service world, but once grandma's dying, they're a really stupid thing to do. It really just harms the family. So if we could get waivers from a lot of that junk, stuff that actually CMMI has given waivers on before, and do a statewide model where we can show that there's a better way to provide care to people at end of life that supports families more, is more humane, and probably ends up being less expensive, we'd like to do that. So there's a rule that says if you want to go from home to a nursing home, you got to spend 3 days and 2 nights in a hospital. Well, first of all, that's expensive. And second of all, if you're dying, you don't need hospital care, perhaps. You perhaps only need to go to the nursing home. And by the way, it's incredibly alarming for the family and for the dying person to have to go and be checked into the hospital and have to go through all that, when all you really need to do is to go to the nursing home down the road. So there's sort of a stupidity and a cruelty and an excess expense aspect to all of that. And it's been a hard row trying to get CMS and CMMI to pay attention to that, and I'm hoping that Secretary Kennedy will.
Are you pleased with the access you've gotten so far to Trump's health team, to
No.
Kennedy, to Oz, to any of them? No.
No.
If you had
No,
any.
they're extremely partisan. They really couldn't care less about anybody on our side of the aisle except to figure out how to make life more difficult for us. So it's a real challenge.
We'll look forward to seeing what fruits come from your meeting. And we thank you very much for your time today and for your perspective, and we'll be watching the Senate.